Hi, good afternoon. I see a lot of familiar faces. Thank you for being here. And um, my name is Kandan. You guys know me, Dr. Kulandaivel, Dr. K. So I thought I could use this opportunity to discuss neurology and balance. The reason I picked up this topic was because the other day, one of my patients I was seeing for headache told me, oh, but you're a brain doctor. Why would you deal with balance? And I was like, hold on. That's not true. We do a lot of balance too. And she was surprised. So that's what made me, okay, well, let me talk about balance. And this is something that is very close to my heart because I always like preventive medicine, where like where you prevent a fall, the patient can have a good quality of life. So I always talk to my patients about it, and so anyway, without further ado, let me start talking. So what I'm going to do in this, I'm going to give you an outline of um, talk about some gait problems, mechanisms of gait, and how we neurologists try to approach this problem, and maybe answer at the end, answer some of your questions. It might get a little technical because I mean, neurology is the only thing I know. So if it's too much, just bear with me, okay? So first, why is this important? Why is gait and balance problems? What is the impact? It's the most common in about 1/3 of people who are more than 60 years, and 25% of all adults in the U.S. More than 65 years had like a fall. So the falls and balance can lead to not only injuries but also reduced quality of life, increased morbidity and mortality. And so what I was saying was gait and balance deficits are also experienced by individuals with a variety of neurological problems. So when we look at structures that are involved in a balance, to take one single step, there is a lot of complex coordination of multiple systems, uh, from brain, from muscle, joint, in order to have achieve that one single step. As you see here in this picture, uh, there is many structures that are important. So from going back, this is what I was talking about, how the gait and balance problems affect people's quality of life, and also a lot of neurological problems can be caused by a variety of systems. So this is what I was showing from a picture standpoint, where like we divide central nervous system and peripheral nervous system, brain, cerebellum, which is the balance center of the brain, inner ear, we call it vestibular system, eyes. They're all important for like balance when it comes to the central nervous system, when it comes and spinal cord too, because the impulses have to go from the brain to the muscles for moving, and the same thing, sensation has to come from the legs to the brain. When you look at the peripheral nervous system, which involves the nerves, muscles, those can also cause problems. If there is a problem there, that can also cause balance issues. So basically, a normal gait and a station requires a lot of coordination between the neuro axis. Um, in order to kind of understand, because gait is so complicated, we kind of like divide into three groups, where which makes it a little bit more for us to approach the problem. One would be gait execution, which is to begin with the thought of walking, what all muscles needs to be coordinated with one leg, the other leg, and how the balance center in the brain has to work, and the muscles. So that's like a gait execution system. And the gait feedback system is when you're standing or when you're moving, the brain needs to know where in space you are. So the eyes and also like the nerves in the legs and the middle ear kind of give that feedback system for helping with the gait. And then the last one is gait support, where that's what we talked about: bones, joint, ligaments, and the heart, because you have to have good heart pumping in order to get your walking. Otherwise, you'll be winded. So think of gait as three systems: execution, feedback, and support. And correspondingly, I mean, there is a lot of overlap, but just from understanding perspective, if there is a problem, the problem could be difficulty with the gait execution. And if it's a feedback mechanism that's affected, then it would be imbalance. And gait support system, if that's affected, it weakness. So we as neurologists divide the problems into these three buckets: difficulty with gait execution, imbalance, and weakness. Of course, there's going to be a lot of overlap, but trying to fit the patient in one of these can help us understand the diagnosis better. So when we will talk about each of these problems that I just highlighted a little bit. So difficulty with gait execution, where what usually patients would complain would be that their rhythm of walking is slow. They cannot initiate a walk, or when they are turning, they have to like kind of like tell the body to turn slowly. The other times patients say things like, I'm my there is a disconnect between my brain telling my feet to move and my feet is not listening to my brain. Some other gait execution functions could be like, limb posturing, where like when you're walking, the hands won't like move, the arm swing won't move. And so those are some of the gait execution problems. And of course, the conditions that can be associated with would be Parkinson's disease, normal pressure hydrocephalus, and basal ganglia, other basal ganglia disorders. So the structures that are usually affected with gait execution all in the brain, like frontal lobes of the brain, or basal ganglia, which is a area of the brain where all the motor circuits like come in. So those are the areas that are usually affected with this problem. The second complaint would be imbalance, where people complain about unsteadiness, and whereby like they are swaying. Some people complain vertigo. Some people say like I can't, like I am wobbly. So those imbalance, or otherwise we use the term ataxia, can be coming from like these systems: the cerebellar system, which is the balance center of the brain, and that is sometimes can be affected with chronic alcoholism or strokes. So that would be one area where people would complain about imbalance. Sensory system is, I see a lot of patients with this problem where people come with like peripheral neuropathy, whereby the legs in the nerves are not like feeling the ground because of the nerves not working 100%. So when they stand up, their eyes usually help them, but the moment the eyes are closed or the eyes are doing something else, they would feel a significant amount of balance problems. And that's how like sensory system affects the balance. The last one is vestibular system. Briefly, the ear has three XYZ axis called semicircular canals, and that connects to your eyes, whereby when you move, it coordinates you with your eye movement. So there is a problem there. People would feel vertigo and basically feel like they are in a boat, or like drunk. But not all my patients drink, so so those are the things that can affect again the balance problems. So coming to the third one is the weakness that I talked about. And the weakness is the most common complaint. People will come for weakness, but the weakness can also be secondary to a joint issue or a rheumatological problem, or sometimes even Parkinson's patient. They would they have this condition called bradykinesia, which is moving slow, and the slowness actually may be misinterpreted as weakness as well. So, and the weakness, corresponding brain structures that can cause weakness, or what we call as upper motor neurons, which is the brain and the spinal cord, lower motor neurons or the nerves, and neuromuscular junction and muscles. So neuromuscular junction means the nerve and the muscle connect with each other, and conditions like myasthenia gravis, and those where the nerve doesn't talk to the muscle often, can cause like weakness too. So again, going back, we talked with difficulty with gait execution, imbalance, and weakness. So these are the three major like groups we kind of look into it. um, I'm gonna take a small detour here just to kind of like show a gait cycle. I mean, it's a little kind of like taxing, but bottom line, gait is complex, and as you see, it can be divided into stance phase and a swing phase. Stance phase is a period where your feet is on the ground, and swing phase is the foot which is on the air, for the limb advancement. So, and again, if you look at breaking down this phases, there are certain times when you need single limb support and a double limb support. So this is one of the things that we make people like walk in our office to kind of see what how much of the stance phase and the swing phase is affected. Moving on, I'm now going to touch what all things as a neurologist, when you guys come see us, that we usually do. Like when we see patients, we try to understand a few things, and I'm going to kind of go through that, and touch everything that we usually do. So first one is walking cycle. A walking cycle, we what we do is we see whether the patient is effortless and stereotypical. I just showed you the gait cycle. We walk them and see like, is there a smooth transition between that initial contact, the opposite initial contact, and the second initial contact? Is there a breakdown on this gait cycle? And again, when you're walking, gait cycle also can help us with the hip problems, because when you're lifting your leg off, you have to have a right angle to the opposing hip, and if that is not the case, then you can have a hip problem. So we look at the walking cycle to see if this is an effortless or a stereotypical nature. Some of the problems that we sometimes see is um, a shuffling, where people are going very very slow, and that is something that we look for in the walking cycle. The second feature that we look for is the posture of the patient. You can see a picture here whereby the general axis should be about 3 to 4 centimeter in front of the ankle joint. So any cervical problem or arthritis or any stooping posture would help us understand about the posture. The next thing is facial expression. When patients walk, are they having apprehensiveness due to fear of falling? Sometimes they are in pain. That can lead us to think that it could be a musculoskeletal pain. So walking cycle, posture, facial expression are some of the things that we look at. More things, or the stride length, like we just said, during the swing phase, whether the patient is lifting the leg up and and comes down. If they have weakness, what happens is there is a foot drop or so, they have a high stepping gait, where they just feel like they every time they walk, you hear that thump. So we also look for that when we look for the stride length. um, And shuffling, I'm pretty sure like people have seen where like they are like very short steps where when they move. And also in the beginning they will have a problem, and then they go and they shuffle. Arm swing is something that is very helpful as well, where like when you walk, you look for whether this arm swing is happening when you're walking. A lot of times if there is a problem in the shoulder, or there is a Parkinson's disease which affects usually one side the most, you would see the side that is affected is not moving. It's not The arm swing is decreased. So that is a clue that like we also look for. Then we look for turning, and turning is also, again, if some patients may have a problem with turning, where they, instead of turning quickly, they have to like break the turning every time they turn. Like they have to break it into multiple aspects of turning, and that can be seen with patients with Parkinson's, where like they turn very slowly. The other things we look for are toe and heel walking. People who have weakness on the muscles of the feet will have problems with toe and heel walking. Tandem gait. Tandem gait is a gait where, like, the cops ask you to walk on a straight line. It is like that, and you have an alternative, one heel touching to the other, and that can pick up a lot of like imbalance problems, and kind of help us understand what is going on. Romberg's test. This is something that has been around for a long time. There is different versions that exist, whereby you ask the patient to stand up and feet together and look straight. And if they are looking straight, and to see whether they are swaying. If their eyes are open and they are still swaying, then it could mean that the balance center is affected. But if the eyes are closed and they are swaying, then it could mean the sensory system from the neuropathy could be affected. So that's a test that helps us a lot as well. The other thing we do is called pull test. Pull test is kind of a little challenging, at the same time scary test, but we've done enough where we will stand the patient, and we would be in behind the patient, and we would trip the patient and see whether they fall, or whether they catch up. Usually patients should be able to like recover from that initial tripping within a step or two. But if it's more than two steps, or if they keep going back, then we think about Parkinson's as well. And again, it's done in a way that even if they fall, they are protected against the examiner, which would be me behind the wall. It's okay. It sounds crude, but when done right, it can help us. So those are some of the things that like we look in our patients as a neurologist to understand which area we put in. And like I said, from weakness, when we examine the weakness, we can find, depending on one side is weak, both sides are weak. That gives us a clue to kind of localize. If it's one side is weak, it could be the brain. If it's or the pinched nerve on that side. If it's both sides, it could be nerve, peripheral nerve, or spinal cord. So again, this is a little too much, but what I was trying to show is like this is a pathway that we use to kind of like, depending on the weakness or gait initiation problem or imbalance, there is a flow sheet of plan that we use to kind of like and go help the patient. You can see here that it is very complicated, but if you're a neurologist, it's not complicated, and we could and go from doing the testing. So there is a lot of testing that we can do depending on what we find. So when we examine you, we get a lot of clues, and with that clues, we would be able to kind of tailor the management better. Um, uh, you guys probably heard me talk about ataxia. Like ataxia, basically ataxia is same as what I was talking about, was the imbalance problems. And again, that is usually from balance center, or from the vestibular center, or from the sensory center. Again, multiple tests can be done for this, depending on um, what company it keeps, right? Like, we always diagnose a disease with the company it keeps. So the sensory deficits versus Parkinson features, then we can, move forward with the workup. Gait execution, again, we talked about it a little bit, where the posture is affected, where there can be dystonia in your hands. And I wanted to spend some time on this step rhythm. Like, we talked about the step rhythm and gait initiation. The step rhythm we talked about in Kandan's, we call it Kandan's changes, where during walking, the short shuffling things can happen. But there is the Kandan's change can also happen when you start walking. We call it freezing gait. And there is one condition which can be helped by surgical intervention. It's called normal pressure hydrocephalus, which is a condition where patient would have um, three W's: wet, wacky, wobbly, whereby they will have a balance problem, they will have incontinence, and they will lose memory problems. So this is one of a promise, not, I wouldn't say promise, a rewarding diagnosis, whereby patients kind of look like very, like, bad and with all these things, but once, if it is the condition and they are appropriately treated, they get a lot better. So as a neurologist, like, we don't want to miss, or we want to find if there is a possibility of this condition. With So when we see people, we talk about the freezing gait, incontinence, or cognitive impairment. And then, if we what we do is, we usually put a needle in the back, take some fluid out from the brain, because of the lumbar puncture, and immediately measure the patient to walk, and see like how better they walk before and after. And if there is a significant improvement, we then send to the surgeon, and the surgeon does the shunt. I've had some patients do very well after that. So again, this is another flow sheet of how we talk about gait execution difficulty. So we can help. We don't treat brain problems only. So we will do exams and try to find out important clues which would help us kind of have a diagnosis and guide testing and management. And thank you for your time. So I'm open to questions. I know. Hi. Okay. So I'm seeing some. I have Parkinson's. What do you suggest to get out of a freezing episodes? Um, sure. So to get out of freezing episode, I mean, it is, as we all know, Parkinson's is a progressive condition. But what I found helpful is physical therapy, um, and medication adjustment. Some, depending on the age and other comorbid findings, there have been some literature about like deep brain stimulation that can help with these as well. Um, so hopefully that. And another question from doctor diagnosed vascular Parkinson due to brainstem stroke 5 years ago. I freeze constantly. PT helps. Oh, there you go. Somebody also agreed with me. But is there anything else um, I can do? Um, Unfortunately, right now, I use a walker, so arm swing. Okay. Um, yeah, unfortunately, we don't have targeted medicines for freezing. But what I have had some patients who tell me that in the morning when they get up, they're very like they freeze and they can't get out of bed. In that situations, medications, we've used medications at nighttime, extended release medications that has helped them with some of the freezing that have um, um, that can help. So can you talk some about vestibular migraine? So thank you. Vestibular migraine. We talked about the vestibular system, whereby uh, the semicircular canals get affected, and then can cause dizziness. So this is a little outside this topic, but I'll touch base a little bit. So vestibular system is important for the balance, and like any system, the vestibular nerve originates in the brain, comes out of the brain, goes to your inner middle ear, and tries to help with the balance, and connects with the eye muscles. So what happens is, um, if there is a structural problem like stroke, or a crystal in the middle ear like falling off, uh, that would cause you to have a balance problem. But migraine is also a condition where there is problems that happen in the brain, and migraine can cause different brain symptoms. And sometimes people will have vestibular symptoms, and we look for the ENT causes, we look for the stroke, we look for any other issues, and sometimes we don't find any reason. In that situation, we raise the possibility of vestibular migraine, and and by process of elimination, that diagnosis is still a possibility. And when you treat with migraine medications, and interestingly, some of them don't necessarily have to have headaches, so it's kind of like a vestibular migraine is a misnomer. But when you give them medications, they do tend to get better, and it's like roundabout, sometimes roundabout way of, we don't know what it is, but because we treated you for headaches and vestibular migraine, it's a possibility they do better, and that's the diagnosis we have. um, oh, okay, you would like to review your diagnostic charts a little bit more. I can do that. Um, okay. And then so I'll come to these questions. At times, I find myself losing balance. Is there anything I can do to improve my balance, such as type of exercises? So again, it's not one size fits all, because, like I just said, we need to find out like what is causing the balance problems. So once we figure out, right, let's say if it's the neuropathy that's causing the balance, or vestibular that caused the balance, I usually work closely with physical therapists, and they can tailor a program appropriate for um, each patient. And this way, like, you get more bang for the buck. If you will not get better in balance if you have a vestibular problem, and they are working for your neuropathy problem. So I think seeing us would kind of be helpful with that. I have neuropathy, drop foot, and here, hold on a second, an inner ear problem. I also have no balance. What can be done to improve my balance? Um, you have neuropathy, drop foot, and inner ear problem. So that's a trifecta. I'm sorry to hear that, but again, which one is more prominent might help. Um, at the end, sometimes we cannot cure everybody or treat everybody, and in that situation we resort to using assistive devices like a rolling walker or a cane. I know nobody likes that, but um, unfortunately, to prevent falls, those gadgets do help. Can the use of compression socks help drop foot? um, Answer is no, because the drop foot is because of a muscle weakness, and a compression stocking will change the circulation, and like and the amount of blood that goes to your foot, but not necessarily help you with the weakness that is there in the drop foot. um, I have MS, and although people wouldn't know it, and any suggestion to decrease weakness and endurance. Um, it so MS again is a chronic progressive disease, and if you're having weakness in your legs, um, I mean, there are different degrees of weakness, um, and if there's a spasticity whereby there is tightness or increased tightness in your muscle, uh, the rehab doctors can help with like Botox injections, whereby they'll prevent it from going contractions, and so that the physical therapist, once you receive Botox, you can work your muscle a little more, and maybe that can help with the endurances. uh, we do see that in people with strokes, after strokes, when they are like in a phase where they get into contractions, you can give them Botox. So maybe that is a venue, if they haven't tried, could be tried for you. What do you think of rock steady boxing with those? um, Okay, so it's interesting. There are like a lot of physical therapy programs for Parkinson's and boxing. I mean, I trained boxing for like 2 weeks, which is kind of like very high into coordination. Um, and most of the programs have incorporated that. And I have a couple of patients who have gone through that boxing type of therapy and found that they have been significantly helpful. There are specific physical therapy programs in our area that do it. um, have you seen balance? Can gait changes and weakness be long term if have migraine? So migraine by definition is like a start and stop, right? Like I mean, depending on what type of migraine, of chronic everyday headache, then yeah, there could be some changes that can happen. But migraine by definition is like episodic, where it'll come and go. So gait changes and weakness, it can happen during it, but why would it keep happening? And that's not something we usually commonly see. Have you seen balance problem with long COVID syndrome? I don't think so. I haven't seen that many of long COVID syndrome. Somebody asked about Charcot-Marie-Tooth disease. I haven't seen a lot, but I do have some experience working in neuromuscular clinic as a resident, whereby this is a neuropathy whereby um, it's a form of neuropathy whereby your leg nerves stop working, and there is also like muscle can be involved. There is multiple types of it, uh, and that can cause ataxia or imbalance issues. um, thank you
Yeah.
for listening, and I hope you yeah, I hope I answered some questions. Thank you.